We're going to go ahead and get started. We might have some folks join us here in a few minutes, but welcome and good evening. We are so pleased to have you at this session. Thank you for being here. And this is a time where we're going to explore the relationship between physical therapy education, physical therapy practice, and the construct of disability. Why now? Why is this relevant or important? Well, as educators, we emphasize and prioritize critical thinking, questioning, and reflective practice. Fields of study, specifically disability studies, are dedicated to examining, deconstructing, and reconstructing what it means to be disabled in the world. These important conversations have been happening for some time, often largely outside of our profession. However, thanks to scholars such as Dr. Barbara Gibson at the University of Toronto, Dr. Dave Nichols, founder of the Critical Physiotherapy Network, as well as scholars and advocates who are on this panel, this conversation is finding its way from the periphery of our profession to center stage. In the article authored by Dr. Amanda Sharp and Dr. Dina Herman, who are both here as speakers today, they charge, quote, while physical therapy knows disability, the profession must also address how disability is known and understood, recognizing that therapists are not as disability literate as once thought, unquote. As we navigate an era where there is more explicit and necessary focus on inclusion, representation, and the need for establishing trustworthiness between educators, healthcare providers, and those we teach and serve, it's exciting to think about this. It's exciting to embark in critical reflexivity, and yes, even some time of wondering about this complex relationship. Through collaboration with these incredible individuals here tonight, we conceptualized a session that fell outside of a traditional panel framework. With a broad array of experiences and recognizing the immense depth that we can go into critical perspectives of disability, we envisioned this as a time of exploration and story sharing. It will be well beyond the scope of this introductory session to go more than surface level critiquing traditional models of disability. But the broader aim of this session is to spend some time engaging in what may feel like a luxury for some of us in the process of wondering. Harking to a step in the process of Harvard's Project Zero, See, Think, Wonder learning strategy, we invite you as audience members to engage in thoughtful analysis of perspectives that are going to be shared here this evening and wonder about how these concepts could meaningfully apply or change our orientation towards the person-healthcare provider relationship. We're eager to share our stories with you and enter into dialogue with you. And with that, I'll do some brief introductions. My name is Dr. Sarah Kasten, and I'm on faculty at Emory University in the Division of Physical Therapy. I am also a member of the Disability Studies Initiative, which is a transdisciplinary group working to have more of these conversations. I am on the editorial staff of the Journal of Humanities and Rehabilitation, and I also serve as the nominating committee chair in the Consortium for Humanities, Ethics, and Professionalism. We will hear from Dr. Dina Herman, who received her PhD in Disability Studies from the University of Illinois at Chicago. She's currently a postdoctoral fellow for the LEND, which is Leadership, Education, and Neurodevelopmental and Related Disabilities program at the University of Illinois at Chicago. Dr. Winston Kennedy is currently a PhD candidate at Oregon State University, as well as a pre-doctoral fellow at Merrimack College. He recently completed the LEND Fellowship as well at the E.K. Shriver Center at the University of Massachusetts Medical School. We'll hear from Dr. Kara Wayland-Smith, who serves as Project Director for Healthcare Workforce Development and Health Promotion Initiatives to improve health equity for people with disabilities at the Ohio College of Medicine Government Resource Center. She's also an adjunct faculty member at The Ohio State University and was selected as one of 2021 APTA Centennial Scholars. We're so delighted to have PT and performing artist Ingrid Masterton, best known for her performance, I Am a Zebra, a curiously entertaining story of illness, which is her one-person performance where she integrates her own lived experiences of illness and disability with her experiences as a provider of healthcare services. In addition to being a performing artist, she's worked as a PT in pediatric settings, has completed doctoral level coursework in disability studies, and has served as curriculum director at Northwestern, creating the master's entry-level program in orthotics and prosthetics. And last, but of course not least, we welcome Dr. Amanda Sharp, who also serves on the leadership board for the Consortium of Humanities, Ethics, and Professionalism. Dr. Sharp is the Associate Program Director and DCE at the University of Minnesota. She is completing her PhD in higher education, specifically exploring institutional factors associated with academic completion for students with physical disabilities who are seeking to become physical therapists. Needless to say, I am so incredibly honored to be a part of the conversation with this brilliant and dynamic group of folks, as well as with all of you. The brief snippets of information I shared with you about their achievements and background will just set the foundation for a deeper time of sharing, where you'll hear from each of the participants about how they arrived at this work related to critical perspectives of disability and rehabilitation, and how these frameworks and truly paradigm shifts in some ways can inform and enhance our profession. These are specific objectives that reflect the notion that we are an ever-evolving profession, and in order to maintain standards of excellence, we will need to move beyond our traditional conceptualization and theories of what it means to work with disabled individuals and what it means to be disabled. Thus, through dialogue, wondering, and storytelling, we will recognize the tension between disability and physical therapy. We'll describe the foundational frameworks of disability that are outside of traditional medical models. We will engage in dialogue surrounding the opportunities for disability studies to inform and further develop PT and PTA curricula. And we'll discuss the value of having increased representation of disabled physical therapists, physical therapy students, and educators. And with that, Dr. Herman, I'll hand it off to you.
Hi, everyone. Thanks for being here. I'm Dina. I am a non-disabled white woman. I have curly dark hair. I've got a scarf in my hair. I'm wearing glasses and a blue and white striped shirt. What we have for you here that we're going to start with is a quote, an idea about disability that we'd like you to consider. I'm going to read it to you. The able body has great capacity for self-transformation. It can be trained to do almost anything. It adjusts to new situations. The disabled body is limited in what it can do and what it can be trained to do. It experiences new situations as obstacles. What we'd like for you to do is think about how the profession understands and thinks and talks about disability. We'd like to challenge you to articulate and reconsider your understanding. This quote, oh, can we go back one? The quote is from Tobin Siebers, and he is a disability studies theorist, and this is from his book, Disability Theory. And in this, he challenges the idea here and the ideas that are, that disability studies also challenges. So challenging negative use of disability, centering, disability studies centers the experience of people with disabilities and seeks to have full participation of people with disabilities in society. Next slide, please. What we'd like you to do now is keep these questions in mind as you're hearing our stories and as we talk about disability. We'd like you to reflect and think about what comes to mind when you think of the word disabled or disability. How do we come to know what we know about disability? How do you view disability as it applies to your work, your relationships, and your own personal goals? Next slide, Sarah. Thank you. We're now going to, as we go through the next few slides, we're each going to tell our own stories. You can go on to the next one. I'm going to start with my own story of what brought me here to disability studies. It was my professional and personal experiences. As a practicing physical therapist, I rotated through departments and settings and had a significant number of repeat clients. They had chronic illnesses, impairments, wounds. The interventions, when they came, didn't necessarily change. I always got them to a specific level of function or healing, but then they'd come back. Something outside of my intervention needed to change, and I wasn't sure what. I also had a few clients who identified as disabled, and I would hear their stories of discrimination in employment, education settings, and accessing transportation. Learned about accommodations, or rather how I was not providing them on the fly. One story that always stuck with me was how I had a client who told me she was a bad disabled person because she became blind from her diabetes. I had no words to discuss with her what it was like to be disabled and not think that it's always bad. I had no way to talk about how society is influencing these ideas of why disability is bad. I eventually had some children, and one of them is disabled. Moving through social circles, school, healthcare systems, even as a PT who, quote, knew disability, I did not know what I was doing. I did not know how to navigate, and I did not know how to talk to people who were working with her or even her about what was in the future for us. I had a knowledge gap on language, and I needed to find some better words to talk about disability. Next slide, please. And so here with this slide, I'd like you to reflect on language that we use around disability. What you see here are a bunch of different words that have been used and talked about when we think about disability. A lot of time disability is always portrayed as a binary to ability or normal. What you see here are some words like wheelchair bound, suffering, burden. Those imply disability is bad or sad. Then you have other euphemisms like special needs or differently abled. These are maybe harmful in a different way. They erase the identity that people of disability that disabled people claim sometimes. It also minimizes the needs that people with disabilities have and are owed under our legal system. Our language constructs disability. It influences how people with disabilities maybe see themselves after they have rehabilitation, and how society thinks about what disability and what normal is. And honestly, what is normal anymore, right? Winston's story will further complicate our constructions. Next slide, Sarah.
Hey everyone, Winston here. I'm a Black male, have a black shirt on, beard, background of outer space because I'm a little out of this world. Thank you, Dina, for sharing your story, and tough act to follow. My experience with disability began from a young age. I was raised by someone with a disability. It was my mom's cousin, she's like my second mom. Growing up in a low income, poor community, you don't really get to understand what disability is. You have so many things to worry about: how I'm going to eat, resources, how I'm getting to school. Everything is based on, basically just surviving day to day. And it's hard to really focus on like certain things when the needs that need to be met are like, pretty basic, right? Food, water, education. And so for me, having my second mom was important because she was the one who showed me love, caring. We go through all these things. And I really didn't know that she had a disability until I started getting older. And then, different subtleties and differences became more apparent because I became more aware. And what that did for me, it helped me understand that people were different. And it took away that kind of value piece, like one way of being is better than another. And it wasn't until I got into my PhD program. So I got my DPT in 2015. And again, just like Dina said, we get this idea of what disability is in this kind of box with that medical model perspective. Medical model says that disability is inherent within the individual, needs to be fixed. We're physical therapists. We're here to fix you, get you normal, and get you doing all these things that are normal and that everyone should be doing. And I think for me, I always kind of took that with a grain of salt because of my experiences, but I never really knew why. And even when I was younger, I had a lot of experiences with, different areas within the disability community. When I was in high school, there was an alternative high school that I volunteered with every summer, because it was fun. And when I was in college, I started volunteering with Autism on the Seas, where you go and you volunteer on cruise ships with families who have children with autism. Again, I did it because it was fun. I didn't really think too much of it. And then I get into the PT world, and my PhD is focused around physical activity promotion. And one of the things that I kind of recognized was within the context of physical activity was the exclusionary practices, specifically within physical activity, right? If we all don't have the same access to opportunities of physical activity like other people. And then, so I'm in my PhD program, it's disability studies program. Again, I'm just not learning all these things. And then I get this layer of intersectionality. So now we're talking about disability, and then we're talking about other identities that kind of incorporate disability too, right? Because people with disabilities aren't just that, women, men, Black, religion, sexuality, all these things are interacting. And yet sometimes we like to, specifically with people with disabilities, like to look at them within this kind of microscope where, all right, now, okay, here's this disability, here's this person with a disability, and it's like, it's hard to see outside of that. And that may come from that complication, with that medical model. So as I was learning about, disability in my PhD program, and learning about intersectionality, and learning about, the history of disability studies, and how, the ADA and the push for disability justice was modeled after the push for social justice. And so for me, those layers always kind of stuck with me, because it's hard to kind of take these identities and say, I know everything about all of these things. We're physical therapists. We know the human body, we know movement, but we don't know enough when that's applied to a human individual, because we can't know that individual, right? And then let's go to the medical model of disability here. So yeah, so we don't know that individual. So what ends up happening, we're trained as physical therapists. We're trained to, use this medical model of disability to help guide us in our interventions. And in certain cases, this is not an issue. Individual comes in with an ACL tear. We know what the problem is. We know what the protocol is. We go in, we do what we have to do, right? But even in that case, there's a time where we have to look past that ACL injury and look at this human being and understand what's going on and how they need to move, how they need to go about their life, and how they need to be incorporated in society while they're dealing with this injury. It's the same for that spectrum of disability. And as physical therapists, I think we're doing a lot better, but there's still a ways to go. And from, again, from my personal experiences, it's not just with that layer of disability, it's really with that layer of disability layered with those intersectional identities. My experience as a physical therapist, just being Black, there's access issues. And if we're talking about that I had this conversation with someone, when you think about this medical versus social model, and we're going to talk about the social model a little later on, but when we think about the social model and saying that society is excluding an individual because of who they are, as a Black individual, that was a case for me, not maybe 50, 60 years ago. The Civil Rights Act was passed in 1964, and we see the movement with the LGBTQ plus community, again, exclusionary practices. So when we see like these models, this idea of disability, and we see this ableism going on, and we like to take this kind of linear perspective, or this kind of narrow view perspective of how to work with people, how to treat people. What we end up doing is doing them a disservice and doing us. And everyone doesn't have my experiences to say, oh, this doesn't seem right, maybe we need to investigate more. But one thing that I've learned that we can all do is incorporate that humility piece, being aware that we don't know, and being able to listen to people gets you a little bit further. And that while we have this medical model of disability and we're going to incorporate it because we're health professionals, knowing when to step outside of that and use that human piece to get at that nuance of healthcare and compassion, I think that's where our profession needs to get to. And I went on a little bit of a tangent, but I'll pass it on to Kara to give her piece.
Thanks, Winston. Good evening, everyone. I'm Kara. For accessibility notes on myself, I am a white cisgender woman and I use she, her pronouns. I do not currently identify as disabled. I have light brown hair pulled back in a bun and I'm wearing glasses. I'm sitting in a chair in my home office and in the background is a gray wall with a photo of 2 zebras. So for me in my story, I've definitely gone on a journey for how I've understood and conceptualized disability. I have grown up with family members, friends, and in my career have colleagues with disabilities. I always knew that I wanted to work with people with disabilities going into my PT career. And reflecting back as I grew up, like many people in society, I think, I definitely held a charity model of disability where the assumption is that disability is inherently a bad thing and that quote unquote good people without disabilities need to help or pity people with disabilities and help them overcome their disability. So going into a career in healthcare, my desire to work with people with disabilities, looking back, really came from a place of ableism and feeling sorry for people with disabilities and feeling a desire to help. But over time, having befriended and worked with many more people with disabilities over the years, as well as interacting more with family members with disabilities, I have learned to correct many of the previous negative and incorrect assumptions about disability that I held and realize the harmful ways that we as a society think and talk about disability and how we are socialized about disability, primarily through media representations. And I know as a student PT and a young clinician, I was continually surprised by the achievements of some of my patients or friends with disabilities when they did something that I did not think was possible with their disability from the training that I had. And over time, I realized that these low expectations that I was conditioned to have about disability was actually directly impacting the types of plan of care I was putting together for my patients and really putting a ceiling on their potential. And as I moved into a career in public health, I realized that all of the health professional training programs that I had been a part of, which included a Bachelor of Science in Health Sciences, my Doctor of Physical Therapy, Master of Public Health, none of these programs equipped me with the knowledge, attitudes, or skills to competently care for the disabled community. And even though we as a profession claim to use the ICF model, there is an underlying assumption that disability is a negative outcome and something that needs to be fixed or avoided, which is much more in line with the medical model, rather than acknowledging disability as an ordinary part of the continuum of diversity of human life and a demographic and cultural identity for millions of Americans. And through further independent study, attending different conferences and working in the space over the years, I've really confronted my own attitudinal biases and ableism and have since devoted my career to correcting the preventable injustices and health inequities experienced by people with disabilities in our healthcare system. They're really focusing on training a more prepared and competent workforce. Next slide, please. So to reflect quickly on the concept of ableism, which is a form of discrimination in which non-disabled people are seen, or rather where people with disabilities are seen as inferior to non-disabled people, and the assumption that people with disabilities are devalued because of their disability. So there are many forms in which ableism can take, but in my work, ableism is very prevalent in the healthcare setting and directly leads to preventable negative outcomes. Just as one example, a recent assessment that we conducted with Ohioans with disabilities found that there were many examples of healthcare provider bias and ableism that were found to be major concerns identified by people with disabilities, specifically citing that it resulted in them receiving inadequate healthcare. And now Sarah is going to show a brief video that provides a nice summary about this concept of ableism.
Sorry, give me one moment.
What is ableism? It is a form of discrimination based on a value system that considers certain body and mind characteristics essential to living a fulfilling life and assumes that the quality of life of people with disabilities must be very low. In ableism, like in racism, homophobia, and other forms of oppression, dominant social groups project their own image as the model for how humanity should be, rejecting or ignoring others as inferior, not normal, or unfit. This bias is used to justify their exclusion, sometimes even their extermination. One example is the eugenics movement, which emerged in the early 20th century and resulted in the forced sterilization of more than 60,000 women, men, and children with disabilities under the pretext of improving humanity's gene pool. In Nazi Germany, more than 300,000 persons with disabilities were exterminated because their lives were considered unworthy. But despite the scale of these atrocities, ableism continues to spread, and its significance remains little understood. Ableist social views still shape our understanding of what it means to live with disabilities and how the lives of people with disabilities are valued. Thousands of women and girls continue to be sterilized against their will, and many more persons with disabilities spend their lives confined in institutions, prisons, or at home, and deemed to be incapable of living in the community. Ableism underpins the way our societies are organized. Basic daily activities, such as going to school or work, taking public transport, doing groceries, or practicing a hobby are made difficult, if not impossible, for persons with disabilities and end up excluded and isolated. Human rights challenge ableism and other forms of oppression and fight for a world where diversity is valued and embraced. Humanity is always changing. People everywhere use their minds and bodies in different ways, and those differences are what makes us stronger. Human diversity is all around us. We are all part of it. Let's embrace it.
Thank you, Sarah. Now I'll turn it over to Ingrid.
Hello, my name's Ingrid Masterton. I'm a white woman sitting in my office, my home office, and I identify as disabled sometimes. So my co-panelists seem to have given us we PTs an awful lot of food for thought and things to consider. But I mean, really, PTs as ableist? I mean, disability is our wheelhouse, right? At least that's what I thought until I started a relatively new PhD program in disability studies some time ago. And I was told by my PT department chair that physical therapy PhD option. So I soon found myself in Disability Studies 501. And whoa, I mean, wait, PT needed to have hard and quantitative science to shore up its practice, but these disability studies professors, they were suggesting that I needed to employ the dubiously rigorous social sciences and the humanities to understand not just disability, but the role that medicine and rehabilitation play in seeming to add insults. Many of my classmates think that as a PT, I didn't have a clue about disabilities, but some of them were openly hostile. Well, ouch. As my co-panelists have said, and as a pediatric therapist, perhaps I've always implicitly known that I was taught in my PT education had a limited usefulness in my practical clinical thinking. For one thing, the term disability, as it's typically used, attempts to describe people with potentially untold variations of impairments. And the implications of those impairments only really have relevance in context. Meaning that the problem doesn't only exist within a person, but rather in the sociocultural and political structures in which that person finds themselves. And can we pull up the next slide, Sarah? This in this slide that's analogous to the one Winston reviewed, a person is a person with all kinds of inherent characteristics. It is, though, the nature of that person's environment, the supports provided and the demands placed. And in fact, my own situation makes the social model of disability a little bit clearer. And the next slide. So I had only briefly considered the irony that I had been able to fund my graduate physical therapy education because I had convinced the government that I was disabled. And even though I only thought of myself as having some proclivity to getting deathly ill every few years, I mean, as a PT, disability is an especially potent stigma to carry. But if I use the disability lens, and in particular the social model, one sees how the context of my life shaped my disability very differently from what a person with the same impairments but a different social context might experience. As a physical therapist, my physical impairments kept me from practicing my vocation as I would have liked. And yet, because of my social context, I, in fact, had a myriad of opportunities to limit the disabling effect of my physical impairments and to reinvent myself. So I just wanted to take some time to look at a couple of elements that for many people present as barriers, but for me had limited consequences, or in fact, number of elements around the outside that if I were to describe my own situation, I wasn't particularly ignorant about the idea of disability illness. I had been sick as a child. My mother was a nurse. I worked in healthcare since the time I was a teenager. So I had a certain degree of understanding and did not generally underestimate the value of people who were ill. I had grown up not particularly, even though I was ill, I wasn't particularly overprotected. My mother came from Germany, and I was raised in a way that stoicism was not only expected but rewarded, which can be useful in the medical world. I was also married. I had a very supportive husband, very supportive and nearby parents and parents-in-laws. I had friends both at work and in my community, in my church, in my neighborhood. My employment that I was working, I was never able to go back to working full time after some point, but my colleagues and my employer were incredibly accommodating to changing my job to be able to, so that I could still work. I already had an undergraduate degree in physical therapy. Yes, that existed back in the day. But I was able to get money from the Department of Rehab Services to be able to fund some further education. And I ultimately was able to find new work in academia and worked full time for some time. My and as they sort of evolve, and I would say that there's still a fear in me because I have some sense of the changes that will happen in my life as some of my impairments become more problematic, and as I simply age, and as I work myself into retirement. So my disability is a product of my impairments and my social context may lead most people into poverty, and I may be moving in there at some point in the future. But you can see by my own example that my disability doesn't look the same as most disabilities, the physical impairments I have, simply because of the social context in which I sit. And rehabilitation therapists to think a bit differently about how we go about doing our clinical thinking and how we think we can actually help people. And so Sarah's going to tell us a little bit of her story and how she came to understand disability.
Sorry about that. Thank you, Ingrid. And allow me just to offer a brief audio description. Again, my name is Sarah Caston. I am a white woman with brown hair. I have in my virtual background a picture of Emory University Hospital. My pronouns are she, her, hers, and I am currently temporarily non-disabled. And so a bit about my story. I resonate a lot with Kara's story. I feel like I resonate with aspects of everyone's story, but I resonate with Kara's in that I went more of a traditional route through PT school. I arrived at disability studies and critical perspectives a little later than I would have hoped now looking back, particularly for a PT who worked with individuals who experienced sudden and traumatic injuries. That was my initial area of clinical practice. I walked the path paved with really good intentions. I wanted to help people. I held and still hold a great deal of compassion and empathy for others. I was able to listen well and be an engaged, compassionate listener in challenging situations. But I did approach rehabilitation very much from a more of a paternalistic, from a fixer mindset, one where I was the bearer of expertise and knowledge. And I held the knowledge about recovery instead of viewing things the other way around, where my patients were the one with the expertise and the knowledge of their own body, their own needs, their own interests, and a higher valuation of their lived experiences over my own knowledge. It wasn't until I heard Nancy Sharby from Northeastern speak about social aspects of disability at one of the CSM conferences early in my career that the puzzle pieces didn't begin to click into place, and new frameworks were introduced. I'll never forget her discussing about how being disabled is worthy of continued examination and advocacy, as it's a group that most of us will at some point be a part of. Hence, I feel like I am temporarily non-disabled. It's from this initial talk at CSM that I continue to explore this critical nature of seating myself more appropriately in the rehabilitation relationship, and where I began to understand that disability meant more than just a collection of impairments or functional limitations. It placed a greater emphasis on the contextual and environmental factor portions of the ICF model. And it also pointed out where the ICF model still falls short in being a model for approaching our individuals with whom we work. It's just recently that I had the tremendous opportunity to collaborate with disability studies scholars, both in and outside of the field of physical therapy. It's through this collaboration and continued ears open, mouth shut approach that I've learned and I'm grappling with the fraught relationship between healthcare providers and disabled folks. It's ignited a passion in me similar to when I started PT school. And my heart's desire was generally to help people, and it still is. While well and good, I've learned that it's more important to partner with, listen to, and engage with people we serve, and treat and promote empowerment and independence. And so with that, I'm going to hand it back to Dr. Dina Herman to take us through a little exercise.
Okay, this is class participation time. We would like to invite you to put in the chat, or do we want people to unmute and tell us what you see here in this picture? I'm purposely not doing a description right now of what these are. I don't see anything in the chat. Am I missing it? Okay, there we go. Okay.
I'm gonna, this Cindy Dodds.
Hi.
Hey, I'm gonna say that for years and years, well, let me back up. I'm a pediatric physical therapist. Specialize and do research and have done clinical practice for years in children that have a lot of medical complexity. I follow and have followed for probably 15 years a quality of life model, trying to move away from a medical model and even a social model, because these are children and their families who are a key part. They want their children happy. They want their children to have good lives for as long as they may happen to be on this earth. And I think that until the whole kit and caboodle of rehab acknowledges a quality of life model for whether you have a ACL tear or whether you've been devastated by some type of brain injury at birth, is critical to what you guys are saying. And I will leave it there.
Thank you for that. Did you want to say what you saw on the screen too? We have a lot of people in the chat, and what I see is everything from describing the picture on the left, which has like a block of cheese and an apple slice cut out, and some people identified it is an adaptive cutting board. To the right, we have a blender. And the next question I will ask you all is, why is the picture on the left adaptive? Why did we decide that that is a therapy tool? And why is the picture on the right not? How did one turn into something that is used for therapy, is now becomes expensive because it's a medical device, and the other one is not? Why do we see these like this? Anyone? This gets back. Go ahead.
I'm always telling patients that assistive devices are just tools. And so it's the same thing as if you were using a screwdriver to do something, you're using a cane to walk. It's just a tool. And so, yeah, I think you have a great question. And, I think it's more than just PTs that have to reframe, because a lot of times the stigma of that is what makes the difference between something that is adaptive and something that's acceptable.
Yes, I think you are touching something there. Somebody else wrote in the chat about biased, able people use the blender. Right, in a way, that tool on the left has become medicalized. We have taken the cutting board, and because we are experts in rehab and disability. We've taken that device and made it something that an expert needs to tell you how to use, right? This gets back into some of our introduction to ableism. And so it ties into this idea that there's a known quantity about disability. It is static and unchanging, and people who are not disabled are controlling the narrative and decided what this is and how it will be used and who will use it. Anyone else want to add anything else to this? Did any of the panelists want to share anything? Because I know when we put this up for discussion, we had an interesting discussion ourselves about what this was and what we thought about it.
Yeah, I'll jump in. So when we were going through this, it went over my head. I'm not gonna lie. I'm like, it's a blender, it's an adaptive board. There are tools. What am I missing? But now I'm like, oh, one will push heavy in PT. Like, you need to now use this because your life is different. And then you have the blender. That's for everyone. When it's like everything's for everyone. We just put certain things in a category for certain people because we're kind of ignorant sometimes.
Right, and that's the way we constructed disability here. People who
Exactly.
the thing on the left are disabled, need help, need whatever it is we're doing. People on the right do not, but really they're just a way to cut food and make it easier.
Exactly.
Mm-hmm. Awesome. All right, I'm going to turn it over to Amanda now, I think, who's going to talk a little bit more about ableism.
Hi, everyone. My name's Amanda Sharp. I'll give the rest of my introduction and tell my story soon. I identify as a cisgendered non-disabled woman. I am Caucasian with sandy blonde hair, clear glasses, and a multicolored top on. And so I'll admit as well, right? So Winston said, oh, my mind was just blown when I saw this thing with the cutting board and the blender. And I had a similar, first of all, I didn't even identify that it was an adaptive cutting board. I sort of thought, oh, I didn't even notice the ridge on the side. And, you know, I might benefit from using that, right? And I don't identify as having a visible disability. So that being said, or any disability at this time. So one of the things that's getting to is this idea of ableism, right? So we saw the video earlier in Kara's section, and you know, we titled this idea everyday ableism, right? So not an ableism that's like, oh yeah, that's totally that's a really intentional thing. Everyday ableism are these things that kind of every day we might not think about, right? Not using plain language and consent forms. Maybe you're a faculty member and you have a student who stutters and you choose not to call on that person. Maybe you're doing it, you don't think you're doing it intentionally, right? There's just some implicit bias, right? Expressing surprise that your provider, your medical provider comes in and is mobilizing in a wheelchair, like, and even to continue to say, wow, I didn't know that insert any individual's profession could do that and use a wheelchair, right? Acting overly nice or offering to help someone with a disability, even if they haven't asked for it. Telling people they're inspiring, right? This is a lot of language around that. So resisting expressing frustration at having to provide accommodations. We'll talk a little bit about accommodations in a later section, but just these sort of everyday things like, oh, I have to do something different, or I didn't think about it that way. And I think lastly, assuming a person can't manage a task or do something because of their disability. I think we talked a lot today already about the lens and the framing in which we approach our work and our profession and our training, right? So inherent to that, intentional, unintentional, is this idea, these sort of underlying assumptions of who can join the profession, what they can do, how they should do it. And so with that, I'll have Sarah pull up this very short but snarky little video clip called trash, or person? Oh, Sarah, will you start it over with the, we're missing the volume. Everybody shut your eyes.
I'm so sorry, guys. Here you are.
Thank you.
We'll replay.
Let's go to school, shall we? Where's the wheelchair ramp? A garbage ramp?
It's not just a garbage ramp.
No, it's a garbage and my son ramp. Okay, crash course in basic human dignity. Let's play a little game I like to call trash or person. Are you Dr. Miller? Trash? Are you a person?
You're
a person, Dr. Miller.
Of course, I am.
Of course you're a person.
Oh, doctor.
So, you know, it's just a quick little, whoops, there it goes. So it's just a quick little snippet, but again, it's not that unrealistic, right? Like that a facility or a building may have a dual access ramp. Just something to think about. So if we go to the next slide, I will transition into my story. And I think one of the things you'll hear is that my story is a little bit different, right? And how I came to this space and came to get connected. But one thing's always been true, right? So one, I'm a lifelong learner. I think all therapists are, whether we like it or not. And I also say that I'm sort of continually discovering who I am, and you know, I'm a work in progress, right? I love that Sarah used the term she's temporarily non-disabled or temporarily able-bodied, however one might describe it. That, you know, I don't have a disability right now, right? That doesn't mean I won't have one tomorrow, or any other day. So we're constantly learning and growing. One of the things that I know for certain is that I'm an advocate, right? So this is what drew me to PT. Anyone who knows me would say I'm easily get fired up or passionate, and will sort of, you know, really, you know, dig in and fight for others, right? I think, again, a lot of PTs are that way. That's what makes a good PT. And so when I started my higher education coursework, one of the things that I had to do was select a policy. We had to do a policy analysis. And I always try to tie what I was doing into healthcare somehow. So I'm like, educational policy, healthcare. So I dug into the Americans with Disabilities Act. And I coupled that with technical standards, right? So technical standards for matriculation, those non-academic factors that we apply in many health professions, especially PT, to students who want to join the profession. And so if you ever thought about those two things together, right? One is to improve access and make sure that all individuals can access spaces. The other, technical standards, to me really seem to do the opposite. And so, you know, again, I'd urge you to consider those two things in parallel and gosh, you know, what are we doing here? And so the more I dug in, I really became frustrated and fired up about these technical standards just really don't make sense. In how are we welcoming students into the profession? And, you know, it's a complex topic. So I'm not going to get into all of those pieces right now, but suffice to say, I'm continually learning how to use my voice and understanding the privilege I have as I move through the world as someone who is currently non-disabled. And so the next slide.
So I just wanted to provide this sort of summary slide. Thank you everyone for just sharing your rich stories, your wealth of experience. I love that we have just a diversity of experiences and different ways in which we've come into this space. And as others have mentioned, you know, I consider myself very much at the sort of the beginning of this journey. I consider myself as very much a learner in this space. And I'm humbled often and always to be here. So if you find yourself, wherever you find yourself, kind of along this spectrum or journey of learning, I hope you feel welcome to speak and welcome to ask questions and share your perspectives as well. So please don't be shy about that or feel like you have to we're supposed to come to this talk knowing a lot of this, because the reality is that we're talking about today is that many of us don't and didn't, and that's okay. We're just excited to continue the conversation and make these shifts. So critical perspectives, they help us, right? They're useful. They're more honest, right? They're just more honest about what's actually happening. We're not just saying, oh, well, of course we subscribe to the ICF model, and that's just an automatically better model. We're critiquing now the model now that's been used for some time, but that still doesn't quite play out biopsychosocially and holistically in practice, right? Like we say that it does, but what does it still center, and how does it center certain experiences, right? So we're critiquing that as well. It challenges what are normative models, right? And ways of being. It outwardly rejects the medical model, which the ICF model also, kind of attempts to do. But we reject the medical model outright because it views disability as being caused by a collection of physical impairments, and negates the other factors that need be considered. I want to acknowledge a hand that's raised. Sue, thank you so much. We'll get right to you in just a quick second.
Thank you.
You're welcome. And critical perspectives also critique current popular discourse, again, that Dina mentioned earlier, that belittles or demeans individuals, whether that's the intention or not, right? I often hear my students still using terms like wheelchair bound, and, some of the terms that Dina reviewed in the word cloud, and it's not with ill intent, but as we know, intent doesn't kind of dictate the course of action, right? It is what actually happens that matters. And so that's what critical perspectives allow us to engage in. So Sue, I welcome your question.
Oh, thank you. First of all, I'm really enjoying the format here in terms of hearing the stories and everyone's journey. So I'll just give a little bit background on myself as I pose my question or comment. So I'll describe myself as a white female, and I practiced as a physical therapist for over 30 years, so giving you some sense of my age. I am currently a faculty member at St. John's University, and my clinical experience had been in pediatrics. And I was fortunate to go back for my doctorate studies in 2012. And that's where I was first introduced to the whole concept of disability studies, because, I went to school at my peak. I went to school in 1979 and got my bachelor's. So I grew up and was introduced to the field as, I'm going to be the one with all the knowledge and the ability to fix someone, and recognizing that, we've really shifting the way that we think. And disability studies was introduced during my PhD course, and we actually had one of our faculty members, I don't know if anyone has read her story, Brooke Ellison. When she was in middle school, was hit by a car, and she's a quadriplegic. And her mom became her strongest advocate, and she ended up going to Harvard, and now she's faculty. So it was just interesting, being with her and hearing her life story. So here I am now, though, working with young families and parents in early intervention, age 0 to 3. And I grapple with understanding my role, and you have young parents, new parents who, they've had all these dreams for their child, and now they're having to come with terms so I think it's really interesting. And again, this is new literature to me, but really thinking about how do I incorporate that into my work with families and parents that might have to be shifting how they view child development and how they view their child being able to become independent in the world and being able to go to school. And so, how do we phrase things? I think about the term special needs and services. And so again, I think right now I'm at a point where I just have maybe more questions than answers, but I think it's a good place to start. So that's why I was also just, I'm really excited to be able to attend the course. And so if anyone has any thoughts or, about the way I'm thinking, please share them.
Ingrid, I wonder if you also as a pediatric PT have kind of a response back or shared experience, or even you, Cindy Dad's.
Well, I too practiced for a very long time, and so came from that mindset, but I had been an ill and disabled kid of sorts myself, so I had some interesting different kinds of perspectives, I guess. So even in my meeting, I more recently I've worked in the NICU, where parents have to face things very abruptly, and I think that my perspective generally has been, and it's notably different than almost every other professional in the NICU, because most of the people in the NICU have no idea what happens to people when they leave. Whereas a physical therapist who worked in outpatient as well, I was well aware of the kinds of lives that these families, or the kinds of challenges that these families would ultimately face. And even in the 0 to 3 aspect, I always kind of focused on, no parent knows what's ahead for any child that they have, and what all parents ever always want to do is provide whatever options and opportunities there are to be made available to their children within the constraints that they can provide that. And I, as a physical therapist, have a certain expertise in understanding something about whatever the particular issues and challenges that particular child might have that I can help the parents to deal with. And that I also always felt that I would usually tell parents that I was very good at my job, but because I do it with all kinds of kids, but that their parent would always be the best therapist for that child, for their own child. Like they would be better at whatever they did with their own child than I ever would. And that's how I tried to think my way through how I could help them. I see Sue has a
Thank you. I'm just trying to remember the name of, she's a mom, and her son had been diagnosed early on with cerebral palsy. And I don't know how soon she became involved in creating blogs and notes and things like that. But thinking about her son differently than she did initially with all the therapies, and she brought light to this whole concept, I think, this whole idea that is all the she posed, and so did her son, what he missed out by having to go to all the different therapies as he was growing up. Thinking about what he missed out on. And I'll try to find the name after I'm done. But, she was not from the health field at all. And it was just through her experiences with the medical field, the medical model, and her son, and just thinking back, times that they lost being with others and just being, as opposed to have to go to therapy sessions. So I found it, interesting and informative to be reading their stories and listening to their perspectives on what his experiences were growing up.
I want to interject something there. This is Dina again. So I'm a parent of a child with a disability, and this is not from my research. This is just my own personal experience. It's a different part of my story, if you will. So our daughter is physically disabled, and she was like looking for her people, and my husband's not disabled. Our other child is not. And we don't have a lot of physically, visibly disabled people in our family. And so it kind of put us on a little search, of who. And again, this is where I felt like I was so lacking as a PT that like, I mean, I knew people with disabilities, but because I saw them in my clinic and I did things, but I didn't really know what their life was like to a degree. Like I heard things, but I didn't really know, right? And so we kind of like helped her like find places. I mean, in school, you have children with disabilities, but that's also a very different environment, right? They're doing different things. They're in special ed, there's adults, et cetera. Seeing adults with disabilities living their lives, doing their things in their communities, a variety of disabilities, was enormously beneficial to me as a parent, as a therapist, and for my kid. And I wonder if there's space for pediatrics and things in our profession. And as I had done my research, you hear this, like one of the things you can do to integrate some of these perspectives, which we're going to get to in a second, is bringing people with disabilities in. What if we're bringing disabled people in to our education system, to our clinics, to kind of give their expertise for things? Like how different would it be for that parent who has a kid with CP who is going to grow up to be an adult with CP, to see an adult with CP in the world doing their things, living their lives, whatever? It kind of shifts and gives you an idea of what it could be. And that's maybe a little bit where, when I talk about that, I didn't have a language, I didn't have words, I didn't have what it was, like that was definitely missing for me, like knowing what that could look like.
And that is a great segue, actually, Dina, into a question that I wanted to pose to you anyway. So at this time, I'm going to, and we welcome more questions. Raise your hand or feel free to put them in the chat. We welcome questions and responses. We want this to be interactive. So I'm going to stop sharing the screen just so we can just have more Zoom face-to-face dialogue, if you will. So Dina, my question to you first, and then any other of our participants can answer, is how do you think additional disability perspectives can be integrated into PT education? What does that look like?
So from my research, some things I learned were, so there's some individual things and organizational things that we can probably do, right? At that individual level, one thing that I think actually might be important for us to remember too, is that if we think about the fact that people with disabilities want and deserve good quality healthcare, it can maybe take us out of that, that medical model where we think that's all we're delivering, and they're not the same thing. And so we can recognize that what we do has value as PTs, and we have a responsibility to provide that good quality care, right? So ways to integrate, having conversations like this, bringing in conversations about language. So when you're talking about impairments and disability, questioning what that is, right? When you're talking about person first language or identity first language, complicating all that. Like, why do we use one? Why is it always a binary? And kind of get them to explore, we don't have to live in a binary. And a lot of times disability is fluid and moves and isn't static. So you kind of got to get used to some of that, right? Bringing in personal narratives, I think, are important. And narratives out healthcare setting, right? There are so many spaces you can look for these things now, right? The internet is amazing. There's blogs, there's Twitter, social media. Alice Wong has a whole book series, Disability Visibility. She does a podcast, like it's fantastic. Experiences with people with disabilities. And one thing I learned is that these cannot be one-off things. So that's a little bit more the organizational area to think about, that your organization maybe needs to think about how can they have relationships with people in the disability community, and look at what those relationships are. I found a lot of the relationships were kind of transactional, where it's very much service delivery. Like, oh, well, we work with this group that's providing wheelchairs or doing wheelchair fittings. What does it look like if you're just in the community with people with disabilities following their lead? Like, what if you have a relationship with the Center for Independent Living and you jump on board behind some of the advocacy that they're doing? So thinking about like what those relationships are is another thing to think about. Another thing, and then I'm going to turn it over to somebody else, is bring in confusing topics like that picture that we had up today challenged our panelists and made us think a little bit differently. So doing things like that and just having it as a jumping off point is useful.
Mm-hmm. Do any other of our panelists want to comment on ways that these perspectives could be integrated into PT education?
I'd like to just say, I think it's important to, because we've sort of wished around different ideas of models. And one thing I found very frustrating when I was teaching was that students grab onto things like that as if they're the gospel. And if they're introduced as simply tools, right? I mean, the models are never meant to describe reality. They're only created to help us find a framework to think through some part of the world. And you know, the ICF is useful in a broad sense. When you have somebody who has knee pain, then maybe you need to really think about the old-fashioned Nagy model and go, what does this look like? You know, when you need to think about broader cultural aspects and psychosocial aspects of illness and disability, something like the social model. But even in with disability studies, there's a myriad of different models. But I think as educators, the biggest thing is to go, in my own particular master's work, I interviewed, I did work on looking at how people came to know what they know, and particularly how the APTA's use of their models was reflected in clinical practice. And it was very remarkable that people who had been practicing for a long time, like me, didn't ever have a model, and went out and went like, well, wait a minute, what? How do we really do this? And then the next cohort age were like inundated with, you know, they were just like, if I had to carry that goddamn guide thing around with me one more time with that. And then the more recent grads were like, well, we understand this is a model that is useful sometimes. So I was like, oh, well, it took us a while, but we got it. But I think that is important, even if you're considering, you know, when you want to think about what disability is, and for it to be integrated in every part of the curriculum and not just something that I will admit, when I had to stop working, I was going to just make my own online thing that I was going to market to medical schools because I knew they wouldn't care, would still pay me. And then I was just morally conflicted with that and decided not to do it because it's really a bad thing to do. But you know, when you're disabled, you have to like figure out how to make money. Anyway, so I think that's a big thing in education. Models are just tools, and to try and get students to understand that from the get-go.
Well, and models and frameworks need to be fluid, right? If we're using the same model in a different society, then we haven't evolved, right? We have not done what we need to do. Paradigms are made to be shifted, right? So with that, Amanda, I know there's a question in the chat that you are going to, I think, address with this next question, if I'm correct. So Wendy, thank you for your question. Amanda, if you'll address Wendy's question, as well as kind of answer this broader question of how can we reconsider access and inclusion for students with disabilities in the physical therapy or physical therapy assistant classroom?
Yeah, so $1 million question, right? If anyone has a straightforward answer, you know, let me know. But I think the reality is, we're gonna have to get real and get real uncomfortable in the fact that, like, you know, there might be other ways of functioning as PTs. And so one of the things that Ingrid was just talking about was this idea of, you know, Ingrid, you're a PT, right? You are a PT who, as you identify, sometimes, you know, you have a disability that's more limiting than others, but the reality is you're still a PT. And so I think one of the things that is really fascinating to me is that employers who have an employee, right, who's a physical therapist or other provider who acquires a disability or becomes disabled in some way, employers will often, not always, but often find a way to accommodate that person, right? They will find ways to improve access and think creatively and in a supportive way. Again, not always, so that individual can continue to do their job, right? Because you don't just wake up and not like, well, I guess I'll go work at the coffee shop. Like, I'm always going to identify as a PT. And so while we see employers accommodating and being really, thinking broadly about the essential functions of an individual's job, or a PT thinking, gosh, how else can I use all of this amazing, training that I have, because I'm still a PT, no matter what other circumstances I'm navigating. We don't do such a good job in education yet, right? Because we are really bound to these technical standards. And I will say, this is not a PT only problem, right? So I think we should be leading the charge in the solution, and we are so behind the ball, and I think we can get there again, but like, we have to talk about it, and we have to think bigger and sort of question, why is it, again, that the able-bodied, non-disabled we have decided how to do PT and how to do PT education. So one of the things is just thinking about technical standards themselves, right? So if I'm an individual with a disability and I'm looking at all the places to go to PT school, and I have two sets of technical standards. Now, mind you, technical standards are neither technical or standard, right? Because they vary from program to program. They're not always available and accessible, and the language is and can be outdated, right? So if I'm looking at technical standards in one program, things are written in a more functional way, where like, oh, I have to be able to access a patient's room. And another program says, the applicant must be able to walk to the patient's room. Right now, the core skill that I think the program is speaking to is that the individual, the provider, needs to be able to access the space and access the patients that they're going to work with. But again, if I'm mobilized in a wheelchair and I've got these two sets of technical standards, one says I have to walk and one says I have to get there, I'm going to probably have to choose the school that says I can just get there. Now, that is problematic, right? So, and that's really, that I use that example to show the difference between an organic and a functional technical standard. I think that's just kind of one little piece of the puzzle. I think the other thing is, and I'll share this a little bit about, technical standards, I think, again, are one piece. How are we messaging? What is the actual language we're using? Are we putting information about accommodations and resources available to our students? I can tell you no, because I've done a study where I went to every single PT program accredited and pulled all of this information. And if I'm a student with a disability, I am feeling very discouraged by what's out there. Accommodations. Legally, accommodations need to be not determined by a program director. Accommodations should not be determined by a PT. Accommodations should be legally determined in collaboration with disability professionals and individuals trained. They need to do it in collaboration with our PT programs and our educators to make sure that all of the things that someone might need to do in a clinical setting or a lab setting can be appropriately represented. But the idea that a student has to go to a program director and ask to be accommodated, and that one person is going to develop an accommodation it's wrong. It's also illegal. And before I kind of get off my soapbox, I realize that I sort of get fired up around this. I'll just share anecdotally some really kind of unsettling things that I am working on getting out there as part of my PhD research. So one of the things that I did a survey, I asked individuals in PT programs to say, hey, what are some of the accommodations that students use in your programs? And talking specifically physical disabilities, and things were reported like, well, students had an accommodation to use their prosthetic limbs. Like, on what planet is so we're including, you know, a prosthesis as a accommodation that someone needs to get approval for. And I think also just actual phrases and people saying like, well, I just don't understand why someone with a disability would want to come into PT when it's just going to be really hard for them. And there's so many other people without disabilities who could come into the profession. So I think we're continuing to hold one way as the right way to do things. And we got a lot of work to do, but we've got a lot of people, I think, interested and passionate about rethinking how we're doing things. I think we can do better. And I think medicine is really kind of beating us to the punch. And there's a lot of opportunity for us to use our skills and our training to set a really good example.
Thank you, Amanda. And Carol, yes, she hears dealing with all the time when referencing student accommodations. Yes, it's precisely that type of language that we as PTs are unfortunately really used to either engaging in or hearing. Our patient is non-compliant, right? They're manipulating us, right? You know, and then this does translate into the classroom, right? We start to look at people who don't fall into our normative values or follow our guidelines as difficult or challenging, right? So thank you for kind of highlighting that. Kara, this next question I want to pose to you first. And the question is, how can attitudes of faculty and clinicians shift to be more inclusive and welcoming of disabled PTs and PT students? So we've kind of highlighted the problem. How can we do this practically?
Yeah, so I think the first step in correcting or shifting these attitudes among faculty and clinicians is exactly what Dina has already touched on, which is to actually engage more with the disability community as peers and not as patients. We need to be working alongside disability self-advocates and self-advocacy groups within our communities, centers for independent living, different associations, different groups that have cropped up in Ohio. We've had a self-advocacy group form because of the need of COVID-19 and the needs of Ohioans with disabilities being overlooked. And so these are really strong partnerships where we need to be actively listening to the community and following their lead and having them as active partners in shaping our content, looking at case studies, looking at how we're talking about disability, looking at our policies and procedures and seeing, maybe some of the things that we're not able to see because we don't have the lived experience. Another way is for people just to be educating themselves about the disability community without putting the onus on people with disabilities to teach us about their lived experience by doing our own homework. There's a vast number of TED Talks of self-advocates with disabilities where we can go beyond what we learned in our professional programs, or often case unlearn what we have learned that is incorrect or negative assumptions, and dig into the literature. There's I see in the chat so many references and books that people are sharing. There's a wealth of information out there if we just go out and seek it. One example is the APTA as a resource guide. That would be a really helpful starting point for faculty and clinicians, and I can link to that into the chat in a moment.
Thank you. And Sandy, you had your hand raised.
Hi, I am Sandy Hannabrink. I'm actually a occupational therapist, but am a disabled occupational therapist and the chair of the network of OT practitioners with disabilities and supporters. So this is, you guys are talking in my world, right? What I think is important, what I haven't really heard clearly is there's a place for medical model in that someone has a medical condition, we're providing treatment plans, and that is a part of what we do, right? that's totally different than disability identity. Now, can that influence someone's identity, and can individuals have a better perspective of embracing disability as part of their identity now? Absolutely. You know, so how we phrase things and not looking at trying to get people, if you're paralyzed, you're not whole unless you can walk, you know, instead of looking at what is it people want to do and how can we get you to achieve those goals while we're trying to help you get to those goals and maximize as much independence and regain as much as possible in a medical world. But I think there's a role and responsibility to helping people to embrace the identity by respecting the identity. In health professions as a whole, we can't take our therapy hats off. We treat everybody with a disability and try to play name that diagnoses, right? We try to play therapist, and that we do that with students, we do it with our peers. I know everybody tries to figure out what my diagnosis is that I work with. And it's just comical because we kind of have a numbers game among friends on how long it's going to take before someone asks, or you hear side conversations. So I think what's important is to embrace identity as just that, identity. Some people with disabilities, like myself, do identify as disabled. Some people are people with disabilities. They don't embrace disability as part of their identity, and that's okay. And we have to be okay with respecting that. But the only way you're truly going to change the profession is when you show total respect for disability identity in whatever way people identify. But if you're asking people with disabilities to come be peer support or guidance or be the expert, then you need to pay them for their expertise and not expect they need to do it for the good of their people. I get asked all the time to come do guest lectures for universities, but they want me to do it free because I'm disabled and don't want to pay my fees, or they want to pay me less, you know, which means they're not going to get me, right? The other is looking at disability within the structures of how your technical standards, what is the outcome you want, not how someone's going to do it. We get wrapped up in you don't do it like I do, therefore it's wrong, because that internal bias that we have of we're here to heal you is so ingrained into the professions and our frames of reference and our research and everything that we do. So you're talking about a total cultural shift of embracing people who have medical conditions and people who identify as disabled as being a part of the health professional world as students. And I think you need to work, when you're working on things structurally, don't interchange treatment and patients with students and professionals, because that's what happens. Every time I go to something, it segues into how I interact with my patients. It's not about looking at students and professionals as just that. And so that's what I caution with as you, and put that challenge kind of out there to think about, is separate it. Medical world, patient. Disability studies, disability identity is about peers and professionals and social justice and interaction. And don't convolute the two, because that's where health professionals have their biggest challenge.
Extremely well said, Sandy. Thank you so much. I really appreciate that.
Sorry,
oh.
Sarah, I want to can I piggyback a little bit on Sarah?
I just want to recognize it's 8:30, but I want to continue this conversation. So for those that can stay, please stay, because I want to hear Cindy's comment as well as ask one more question that I think is really important. So if you can stay, great. If not, thank you for joining us. But Cindy, please go ahead.
I think that's my point about, it's probably a little left to what Sandy said, but it's about, it steps away from that medical model into the quality of life model. What does Sandy want? I think we get tied into what we as PTs have been educated and have practiced to do, but what does Sandy want? Does Sandy want to be recognized as disabled? Or does Sandy want to not be recognized as disabled and she wants us to help her restore her ability to walk? And I think that's the basis for what I'm saying about quality of life. It's not really what I want for Sandy, and it's not really about PT education. That's what PT students and faculty and researchers want for Sandy. It's about, what does Sandy want and how do I make that happen? And to me, that is so founded in Sandy's quality of life expectations, not my quality of life expectations for Sandy. Sorry, Sandy, to make you an example, but hopefully you're okay with it.
I'm used to it. Don't worry.
Great, thank you. The last question for those that are able to stay on, because I just did not want to skip it. Winston, it's for you. Can you just comment on how disability identity, as Sandy gave us the perfect segue, intersects with other marginalized identities or groups?
Oh, definitely. And I'm glad I wasn't the only one who caught that. That was a perfect segue. That's awesome. Yeah, disability identity, intersectionality. That's honestly something. This is something that is very new to me. But in this country, over this pandemic, a lot of things came to light that we probably might have thought about or knew of, but it wasn't in a social, arena. And that's like a big part of it is race relations. Before that, it was gender, right? And all those things, especially in America, play a big part in our health, how we participate in society. And it's a good thing that as PTs, we're able to have these discussions on disability, but unfortunately, we're not there yet with some of those other topics, right? Like PT doesn't talk about race very well. I've unfortunately been a part of attempts to have those conversations. Doesn't go well. And we're starting to have better conversations about gender. I know the APTA is talking about the gender pay gap, which is awesome. So, we're learning more about that. But those kind of things affect us. And if you identify as those things, they kind of can compound on each other, right? And that's kind of at the heart of that intersection approach and how those kind of incorporate with each other. So I'm a black male. So as a male, of course I have privileges, but as soon as you add that black on there, there's a layer of barriers that were brought up. And then, my disability identity, I'm still working on what that means for me. But when you add that, again, that's another layer of barriers because of, again, how this country was constructed. We talked about a lot about how we think about things, right? And like how we view these things, both explicitly and implicitly. And that has an effect on our attitudes. That has an effect how we interact with people. That has an effect on, as healthcare professionals, as PTs, the type of interventions we want to use, if you want to be aggressive, or if this person is, unmotivated or non-compliant, or, they wouldn't want to do this anyway because, this type of person generally doesn't do that. So I'm not even going to cross that bridge, so those identities, the intersection of those compound on each other, and it becomes this kind of tiered, layered experience. A man with a disability does not have the same experience as a woman with a disability. A black person with a disability doesn't have the same experience as a white woman as a white person with a disability. So we need to take that into consideration when we talk about, disability identities, when we're talking about, people in general. And I think Sandy hit it on the head. It's just like listening to the person and letting them tell us who they are and us respecting that. And I think we can do it, but sometimes our education gets in the way of that, because in a certain way it has to, right? Because we have to be leaders. People have to follow us, and people need to listen when we speak. And some people know how to do that naturally, and some people may need to kind of learn how to do that. And sometimes that can get kind of convoluted by dictating things instead of having an open conversation with someone. And unfortunately, depending on those identities and how they intersect, that can become more or less, right? So yeah, that's kind of like my perspective on the whole piece.
Thank you so much. Ingrid, you had some parting words, I think, to close us out, and I would love if you'd share this, and then I promise we will let you all go on with your evening.
Okay, thanks, Sarah. Well, thanks everybody for joining me and my colleagues for this evening of dialogue, exploration, and wonderment and learning. And thanks, Sarah, for initiating and organizing this event. And thank you to Sarah and my other co-panelists, Dina, Winston, Kara, and Amanda, each of whom has come from and are moving toward a myriad of understandings of disability. They've each allowed themselves to be uncomfortably pulled by the tension between the concept of disability and the profession of physical therapy. And they've shared their stories with their own vulnerability about trying to get it right. Yet ultimately, we each will have to reconcile ourselves to the idea that there's little about the concept of disability that is anything less than ambiguous and fluid, anything less than what it is to be human. And we hope that you recognized in the format that we've chosen to use to present that we've tried to reflect a sort of tweaked kind of thinking about the scientific method, a method that rather than starting with a problem, starts simply with a story about a person or people experiencing their lives in their own cultural space, time, and place, and then determining whether or where, as a rehabilitation professional, we might have a role to play. Maybe not just trying to fix an impairment, but also perhaps being a driver of cultural, societal, or political change. And that change would include integrating the concept of disability throughout physical therapy curriculum and opening physical therapy education to persons with disabilities whose experiences can inform our profession. We also hope that you recognize that what disability studies brings to rehabilitation sciences and practice. That is critical theory in scholarship, such as used in gender, African American, and queer studies. While quantitative data is important to discern techniques to address the challenges and impairments, the challenges that impairments might create for people, including people with disabilities, it's the social sciences and the humanities that are best used to help us identify what those issues and challenges are. What questions should be asked? Who should ask those questions? How those questions should be best asked and studied, and toward what end any proposed intervention should be developed. And lastly, perhaps my own story best exemplifies reconceptualizing the person-provider relationship. While my impairments keep me from practicing as a PT in a manner that I would prefer, it is the social context and the humanities that have supported me in reinventing myself and ultimately reinserting myself back into this world of my beloved vocation in a whole new way. And we all look forward to collaborating with each of you to assure that physical therapy as a profession uses the tools that we've discussed, such that the profession will both come to reflect the people whom it serves, and it will use the wisdom of those people to support nothing less than the reinvention of the profession itself. Thanks, everybody.
Thank you all. Good night.